Dear students, the topic of lecture is Ethical Principles of Medical Help in Oncology. The medical subspecialty of oncology presents diverse ethical dilemmas, often challenging healthcare workers with difficult to handle clinical scenarios that are tough from a personal and professional perspective. Ethics is an essential and inseparable aspect of clinical medicine, and the oncologists, as well as the allied healthcare workers, are ethically committed to helping the patients, avoiding or minimizing harm, and respecting the patient's values and choices. To ensure that medical professionals establish ethical competence, moral and ethics education should start at home, continue at medical school, and continue beyond graduation of the medical school. Healthcare personnel face many ethical challenges, and lack of training often leads to mismanagement, impacting decision-making and unresolved conflicts, resulting in discontent, distress, and moral injury. Distress further leads to a job dissatisfaction and fatigue, compromising patient care and the reputation of the healthcare establishment. Medical ethics is based on Bishop and Childress ethical principles of autonomy, beneficence, non-malfeasance, and justice. Healthcare professionals must keep this principalistic approach in mind and make the best decision and choose the best interventions in the best interest of the patient and their family. Given this, structured bioethics training and a rigorous approach to ethical issues would assist healthcare professionals in those ethically challenging situations. Oncology, as a medical specialty, is devoted to the diagnosis and treatment of cancer and provides follow-up care and supportive care for terminally ill cancer patients. Palliative care in the specialty deals with pain management and associated discomforts. Community oncology services educate the public on cancer prevention, sensitize them, and screen population for cancer. Today, oncology is one of the key medical subspecialty filled with divergent ethical issues. The ethical problems can be divided didactically into three categories. Moral uncertainty, when there is a question on inadequate or incorrect position and a feeling of tension, frustration, and annoyance, but such a situation is not perceived as part of an ethical problem. Moral dilemma, which is characterized by two distinct paths to be followed, however, with a single option to be chosen, and moral suffering, situation in which the medical specialists know what is correct and what should be done, but is prevented from doing so for some reason, either individual, institutional, or social, and may not follow the path of own conscience. More extensive and complex than the division presented, routine plot present in the oncological context shows a range of moral issues that cannot always be classified in literature, demonstrating that the ethical dimension remains marked by the need for constant reflections. Nursing objectives in oncology are clearly ethical: to protect patients regarding disrespect to their autonomy, to provide dignified care, and to prevent damage and potential complications by maintaining a healthy environment for patients and their family. Similarly, the law on health, an inherent part of nursing goals, has been considered an inseparable element of the nursing professional ethics, including the nurses' efforts to promote the welfare and interests of their patients, aiming to ensure their autonomy in decision making. In the oncology context, nursing professionals maintain a close contact with situations of pain, finitude, and death, physical and emotional side effects, hopelessness, anguish, fear, and loneliness, intense and denouncing feelings of human fragility, at the same time that an expectation of curing the disease may be present. Oncology is an area of constant ethical problems, experienced from situations already considered part of the professional routine, such as lack of informed consent of patients before diagnostic and therapeutic procedures, the extension of life without concern for its quality, and questionable and heteronomical professional practices. Regarding the increased use of technologies and medicines for treating oncological patients who no longer respond to available therapies, professionals often experience the life extension of the patient without reacting or positioning. All these situations awaken the need of advocacy in health by the nurses and integral part of the nursing care related to the defense of the rights and interests of patients, avoiding patients and their families to be exposed to a variety of situations that cause suffering. Nevertheless, health advocacy actions performed by nurses in oncological and palliative care can be defined as assisting patients and families to overcome the difficulties hindering the path of care, informing and clarifying them, as well as defending their choices and acting as a link between them and the health staff. However, many issues experienced by professionals every day are only perceived as organizational problems and conflicts and or regarding the relationship in nursing and health staff related to directors, managers, patients and their relatives, and not in its ethical dimension. Such conflicts can occur when there are differences in understanding a given situation which cannot be adequately communicated, understood, and resolved. The ethical problems are questions for which the answer is not initially present, and there is no way of knowing whether and how it might be resolved, and therefore the question is not only about the choice between two or more possible answers, but also about searching a unique and appropriate response to each situation. Thus, it is appropriate to recognize the ethical dimension of the problems experienced by oncology medical professionals, stimulating them to reflect and question the realities presented. Autonomy in medicine is the rational ability to make voluntary decisions about medical options and live one's life according to one's true principles or desires. It embodies the right to exercise and express independence in healthcare. Without autonomy, even the best therapy violates medical ethics and the professional legal framework. Consent and assent derive from patient autonomy. When there is a disagreement, the patient's wishes and values outweigh the healthcare worker's priorities. Once diagnosed with the disease, cancer patients and their families can choose their doctor, hospital, and type of treatment. Even after understanding the therapy and risk-benefit variables offered by the oncologist, some patients choose unproven modalities based on personal beliefs or family experiences rather than medical facts and treatment options. Oncologists face ethical dilemmas when patients or families reject mainstream oncological care and choose unproven therapies. In these situations, the dilemma is on whether to prioritize patient autonomy or beneficence. Oncologists struggle to keep patients hopeful and help them choose and follow conventional care. Respect for patients requires that healthcare professionals foster patients' control over their own lives and refrain from carrying out unwanted interventions. Fully informed consent is an ethical ideal that is seldom realized in practice. Obstacles include diagnostic uncertainty, the complexity of medical information, linguistic and cultural differences between clinicians and patients, overworked medical personnel, and psychological barriers to rational decision making. Consent can be defined as the autonomous authorization of a medical intervention by individual patients. Capacity refers to the patient's ability to understand the information and to appreciate those consequences of his or her decision that might reasonably be foreseen. Voluntariness refers to the patient's right to come to a decision freely, without force, coercion, or manipulation. Consent may be explicit or implied. Explicit consent can be given orally or in writing. Consent is implied when the patient indicates a willingness to undergo a certain procedure or treatment by his or her behavior. A signed consent form documents does not replace the consent process. If a signed consent form is not required and the treatment carries risk, clinicians should write a note in the patient's chart to document that consent has been given. Obtaining valid consent requires that patients participate in problem solving as much as they wish. Patients should be free to ask questions and receive answers about treatment options not discussed by the clinician. The consent process also requires that patients actively participate in decision making and authorize their decision. Even if the patient is predisposed to follow the clinician's recommendation, the clinician should actively engage the patient in the consent process. The principle of informed consent incorporates the patient's right to choose from among the options presented by the physician. Medical oncologists and the healthcare team should guarantee the involvement of any patient in their decision-making process, supplying information that is appropriate to individual needs and carrying out effective communication with patients and their families. The medical oncologist and the healthcare team should supply information tools to the patient. That information regards the person's state of health so as to ensure that he or she can make choices uninfluenced by external pressure. The medical oncologist and the assisted persons should exercise their legitimate role in treatment decisions, starting their preferences and the rationale for their choice in the attempt to construct a consensus on the most appropriate treatment. Informed consent is the most significant medical ethics process, which is based on free choice and voluntary decision made by a competent or autonomous individual after disclosure of sufficient information and consideration. To help capable adult patients make informed decisions, doctors must disclose all pertinent information to them and their families. Parental and child-adolescent consent is recommended for patients over 7 and under 18. In emergencies and when the patient is orphan or physically incapable, the physician may make decisions based on what is best for the patient and beneficent. It is legal requirement to obtain informed consent which aims to protect the patient's autonomy. In oncology, the informed consent process for therapeutic interventions differs from that of clinical trials and research. Before starting routine clinical care, the treating doctors explain to the patient and family or carers about the treatment purpose, techniques, alternatives, costs, risks, advantages, rights, and decisions to assist the patients and their family members in making informed decisions. Oncologists must decide how much information to give cancer patients for informed consent without causing them undue distress. Each patient's disease type, status, and stage demands a unique informed consent form, either a custom-made written one or a printed form. In oncology, getting informed permission for vulnerable patients who are unable to make decisions owing to medical, educational, or linguistic obstacles is vital and legally binding during treatment. Capacity is a complex construct that refers to the presence of a particular set of functional abilities that a person needs to possess in order to make a specific decision. These abilities include being able to understand the relevant information needed to make the decision and to appreciate the relatively foreseeable consequences of the various options available. In the medical setting, the key decision to be made is whether to give or withhold consent to investigation or treatment. The presence of decision-making capacity is an essential, although not sufficient element of valid consent. It is important to remember some underlying considerations concerning capacity. Firstly, capacity is decision-specific. Secondly, there is a presumption in favor of capacity. Finally, there must be a commitment to enhance decision-making capacity as much as possible. The interview process has an enabling function as well as one of assessment. Enabling strategies might include treatment of an underlying mental illness, reducing the impact of prescribed medication, or in case of fluctuating capacity, waiting to assess during a more lucid period. The assessment of decision-making capacity should begin with a discussion of the person's understanding of the disorder for which they are being offered treatment. This is then followed by a discussion of the recommended treatment, its benefits, the risks of refusing this treatment, and any available alternative. Patient may be able to provide information in those domains in response to open questions. However, the relevant information may need to be disclosed and redisclosed as the assessment progresses. It is essential to document the capacity assessment not only for clinical but also for legal purposes. Beneficence emphasizes the physician's duty to alleviate patients' suffering and avoid bodily, moral, and mental harm, which is underlined in the Hippocratic Oath. Beneficence considers well-being as a moral issue and is often seen as selfless and non-obligatory. Beneficence is subjective and often physicians' view of medical benefit differs from the patient's perspective, and doctors have a moral obligation to prevent any harm. Medical disputes should be discussed and resolved to prevent any future breaks in doctor-patient relationships. Doctors should respect the human rights, decency, and confidentiality of patients under their care. Breach of confidentiality can cause loss of trust, psychological discomfort, or financial loss for the patient and may lead to litigation later. Oncologists face ethical dilemmas while treating patients with poor prognosis, comorbidities, and in the absence of family members to care, which is not uncommon. A kind approach is needed from the healthcare provider, taking into consideration the patient, family, and their socio-economic status while planning the treatment. Doctors should use their best discretion when given unpleasant news to minimize distress to patients. The treating physician should also consider pharmacoeconomic to lower treatment costs. If the carer is elderly with health issues, the treating doctor has to consider ways to assist both the patient and the carer. In brief, the beneficence includes the selection of the optimum and effective treatment modality with minimal side effects, ensuring a better quality of life. From an ethical perspective, beneficence requires that pain and other symptoms be controlled. Advanced care planning is used to justify much decision-making at the end of the life and is ethically supported by respect for autonomy and is legally recognized in most Western countries. No patient should die in pain or with other treatable symptoms. The recommendations for communication with patients with pain and comorbid mental disorders had been formulated recently by Dr. Anton Pokalyuhin, psychologist and co-founder of Ukrainian Psycho-Oncological Association. Medical communication goes beyond simple politeness. It is a key factor in improving patient care. For patients with chronic pain and mental disorders, clear and empathetic communication builds trust, reduces anxiety, and strengthens adherence to treatment. Miscommunication can exacerbate both their physical symptoms and mental health challenges. Good communication is particularly crucial in situations where medical interventions are limited, shifting the focus to providing empathy, psychological support, and engaging patients in understanding their treatment. Patients with chronic pain often have poor compliance with treatment regimens. Effective communication can help improve adherence to prescribed therapies by clearly explaining the benefits, addressing concerns, and fostering a collaborative relationships. Patients with pain and comorbid mental disorders frequently need to discuss sensitive issues, among these stigmatization and incurable forecasts. Empathetic communication is key in addressing these topics effectively, helping to alleviate additional stress. Chronic pain should be managed using a biopsychosocial approach, which considers a wide range of factors that affect the patient's quality of life, including psychological characteristics, social circumstances, and biological vulnerabilities. If patients are unaware of or do not accept this approach, it can lead to dysfunctional behaviors and a chronic pain cycle, where pain leads to reduced activity, worsening physical condition, and increased emotional distress, including depression. Effective communication can help patients understand and accept this approach, leading to better management of their pain. Four main objectives guide effective communication with patients dealing with chronic pain and comorbid mental disorders. First of all, building a therapeutic partnership. Empathy, trust, and clear communication are essential for gaining patient trust, which leads to better cooperation and adherence to treatment. It is important to involve patients in decision making. Actively engaging patients in their treatment plans improves satisfaction and treatment adherence. Even small increases in consultation time are worth the benefit of patient involvement. One more important task is to provide clear and understandable information. Many patients struggle to understand chronic conditions like long-term pain. It's crucial to simplify explanations and manage expectations around treatment outcomes. The next important task consider emotional and cognitive factors. Understanding and addressing the patient's psychological and emotional state are just as important as focusing on their physical symptoms. Emotional distress can worsen their perception of pain, so attending to these aspects enhances communication and care. Then practical tools that healthcare providers can use to improve communication with patients suffering from chronic pain and mental health disorders are introduced as, first of all, nonverbal communication. It is known that over 90% of communication is nonverbal. Eye contact, body language, body posture, and facial expressions are essential for building rapport. Often we don't notice nonverbal signals, yet they are informative. They deserve just as much attention as verbal communication. These three elements of nonverbal communication should be especially considered in interactions between patients and providers. So, first of all, when you start a consultation, take a moment to make eye contact. Regular eye contact shows you are present with them. At second, how the provider and patient are positioned in space is also important. Give preference to sitting over standing. Try to be at eye level with the patient and minimize the number of physical barriers between you and the patient. The third recommendations means that patients quickly notice signals from your expressions and words. Ensure they match. For instance, if you frown and shake your head while reviewing test results, but say everything looks good, it might alarm the patient. Ensuring that nonverbal cues match verbal communication is key to avoiding misunderstandings. One more important skill is active listening. Active listening involves focusing fully on the patient, avoiding interruptions, and using verbal and non-verbal signals to show understanding. This includes repeating or summarizing what the patient has said to confirm comprehension and engagement. First, listen without interrupting. Let the person speak completely, especially at the start. Second, use facilitation, like notes or short verbal prompts to encourage them. Third, use repetition and rephrasing to confirm understanding and show interest. Finally, summarize their points to ensure clarity and show that you have truly understood their concerns. These techniques form the foundation of effective patient-doctor communication. The ICE model, which dechiffrates as ideas, concerns, and expectations, will help you. This tool helps healthcare providers to understand the patient's perspective. Asking open-ended questions about their thoughts, concerns, and expectations ensures that the patient feels heard and their worries are addressed, which can help tailor their treatment plan to their specific needs. To use the ICE model effectively in practice, the key is to create a space where patients feel comfortable sharing their ideas, concerns, and expectations. Begin by asking open-ended questions like, what are your thoughts of this diagnosis? Or do you have any concerns about starting this medication? These types of questions encourage patients to share their perspective, which can help guide your treatment plan. Pay attention to nonverbal cues, as patients don't always express concerns verbally. A shift in body language or a change in expression may indicate underlying worries. When you notice this, gently address it by saying, I noticed you seem hesitant. Do you have any concerns about the plan? This can open up a dialogue about any unspoken worries. Active listening is essential in this process. Make sure you are not just hearing by the patient but reflecting back what they have said to ensure understanding. This demonstrates that their concerns and expectations are valued, building trust and fostering a collaborative relationship. One more helpful model is ERAS, which helps providers validate a patient's emotions. Imagine constantly feeling misunderstood or dismissed about your pain. For patients with chronic pain or mental health issues, this is a daily reality. We as medical professionals can improve their experience and outcomes through validation. The acronym ERAS helps to remember the building blocks of validation. E may be deciphered as emphasize the normalcy of emotions, reassure patients that their feelings are normal and others in their situation would feel the same. This reduces stigma and encourages openness. R means recognize the validity of the patient's reasons. Validate patients' emotional responses even if their reasons seem trivial. This shows respect for their feelings and fosters a more collaborative relationships. A. This is acknowledge their current circumstances. It means that you should recognize that a patient's emotions are often a reaction to their situation. Acknowledging this helps normalize their feelings and reduces anxiety or shame. And S means share your observations. Acknowledge patients' emotions like frustration or anxiety, even if they don't express them. This shows empathy and understanding, builds trust, and encourages open communication. To avoid either overwhelming patients with too much information or giving them too little helps striking the right balance. That is crucial for effective patient communication. Start by asking how much information the patient wants. Not all patients want detailed explanations. Some prefer only the basics. Tailor your message to match their preference. Use simple, everyday language instead of medical jargon. Avoid oversimplifying, as this can come across as patronizing. The goal is clarity without condescension. Break down the information into small, digestible parts, use short sentences, and pause to allow the patient to process. Always provide the most critical information first. Periodically summarize what has been discussed to reinforce understanding and maintain focus. This helps the patient keep track of complex information. Ensure comprehension by asking open-ended questions that invite the patient to summarize what they have learned. Avoid yes or no questions to encourage honest feedback and better understanding. The speaker's model provides a structured approach to delivering difficult information. Delivering bad news is one of the most challenging tasks in healthcare, and the speaker's model offers a structured way to approach it. So first, necessary to ensure the setting is private and calm, creating a comfortable environment for the patient. Next, assess their perception by asking what they already understand about their condition. This helps you gauge how much they know and tailor your message accordingly. Then offer an invitation by asking how much detail they want. Some patients prefer a lot of information, while others may only want the essentials. When it's time to share the news, provide a gentle knowledge, warning to prepare them emotionally, such as saying, I'm afraid I have some difficult news. Be clear and avoid medical jargon to keep the message simple and understandable. As emotions arise, respond with empathy. Acknowledge their feelings, offer support through nonverbal cues, and give them time to process. Lastly, summarize what you have discussed and outline the next steps, ensuring the patient knows they are not alone and that there is a plan moving forward. This structured approach helps deliver difficult news with compassion and clarity. It is evident that effective communication is key to better outcomes with chronic pain patients. By fostering mutual understanding and respect, we can greatly improve our care and increase patient quality of life. Disclosure refers to the process during which physicians provide information about a proposed medical investigation or treatment to the patient. Disclosure, along with capacity, understanding, voluntariness, and consent, makes up the main elements of informed consent. Truth telling in healthcare may be defined as the practice and attitude of being open and forthright with patient. That is, it is about encouraging authentically and genuineness in the relationship between healthcare professional and patient. Truth telling requires the belief that in general truth is better than deception. It also requires an intent and effort to be as accurate and honest as possible with patients and includes the duty to disclose information for consent purposes. Failure to provide the patient with treatment information may give rise to a claim in negligence, but only in disclosure has fallen below the required standard. The standard could be what the medical profession considers appropriate, so-called the reasonable doctor standard, or what a reasonable person in the patient's position would want to know, which is characterized as the prudent patient standard. The goal of disclosure is to ensure that patients have appropriate information to make an informed choice about their health care. Effective disclosure requires open and balanced communication. In the medical consultation, the clinicians must decide what ought to be communicated, and the patient must integrate that information into their medical and social life experiences. Truthfulness in medical ethics is now considered as moral norm. In the past, physicians were the only decision makers who could withhold information from patients, especially about life-threatening and stigmatized conditions. This paternalistic legacy gives false optimism and disrupts patient-doctor relationships. Most Western doctors feel patients have a right to know their diagnosis and reveal them, while many Eastern cultures do not. Clinically, withholding prognosis and diagnosis violates patients' autonomy and may jeopardize the rights of the patient. Given this, many bioethicists believe doctors should always give patients the truth and clearly information, sincerity, and honesty. Breaking the bad news is the hardest part of cancer disclosure. It often entails various ethical issues, and patients and families' right to information about their diagnosis and illness. The literature sources recommend to start with suspicion or possibility of cancer and tell the facts after a diagnosis. Breaking bad news includes cancer confirmation, surgery-induced physical disfigurement, chemotherapy or radiotherapy-induced fertility loss, treatment-induced irreparable health prognosis, recurrence metastasis post-treatment, palliative treatment, and end-of-life care. The treating doctor must consider not harm and how much truth to tell in those circumstances. Clinicians must respect their patients' confidences. Private information, particularly if identifiable, should only be disclosed to a third party with the consent of the patient. If the patient lacks competence, then, depending on jurisdiction, either the consent of the patient's representative is required or disclosure should be discussed with the patient's representatives and only occur if it is in the patient's best interests. Clinicians should be aware of the legal requirements for disclosure of patient information in their own countries and whether possible discuss such disclosures with patients beforehand. Pain is a common symptom of cancer diagnosis and rises in prevalence throughout and beyond cancer treatment. In a recent systematic review, the overall prevalence of pain in cancer patients was 44%. Moderate to severe pain was experienced by 31% of the patients. Approximately 1 in 5 adults worldwide suffers from some reason chronic pain. As one of the leading causes of disability, it affects around 20% of people globally. That's why it's essential to develop a clear and thorough approach to pain and its assessment. Pain is a complex experience not limited to physical sensations, but also involving emotional components. It may occur without visible tissue damage, and its intensity doesn't always correspond with the level of physical injury. Effective pain assessment requires a comprehensive, patient-centered approach that considers both the biological and psychological aspects of pain. Empathy and clear communication are crucial for understanding the patient's unique pain experience, ensuring that they feel heard and receive appropriate care. The individualized approach is key to enhancing treatment outcomes and ensuring patients' comfort. Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain is a part of the body's protective system. It acts as a warning signal of imminent or actual damage. In this respect, it has an important function in maintaining or restoring physical integrity. However, it may also occur without any tissue damage, and its intensity may not correlate with the actual damage. Pain is influenced by a complex mix of biological, psychological, and social factors, and physical aspects like genetics, injury, and lifestyle choices can shape how pain is felt, while psychologically certain conditions like anxiety and depression can amplify the experience of pain, creating a cycle that can be hard to break. Social challenges such as relationship issues or stress at work can further exacerbate pain and lead to social isolation. By recognizing these interconnected influences, we can approach pain, especially when it's chronic, in a more holistic way. The biopsychosocial framework is the backbone of any successful treatment strategy. The PQRST approach is used to guide this process, focusing on 5 key areas: provocation and palliation, what triggers or alleviates pain, quality, the nature of the pain, region or radiation, where the pain is felt and whether it spreads, severity, which means pain intensity, and timing, when and how often the pain occurs. Begin by asking the patient what provokes or alleviates the pain, followed by exploring the quality, whether it's sharp, dull, or throbbing. Next, assess the region and whether the pain radiates elsewhere. The severity is often rated on a scale such as 0 to 10 to gauge intensity. Lastly, inquire about the timing, when the pain occurs, how long it lasts, and whether it follows any patterns. Using this method ensures a structured and thorough pain assessment, aiding in accurate diagnosis and effective treatment planning. At the first assessment of the patient, the PQRST approach should be seen as part of a broader strategy for understanding pain. Three additional elements must be included to ensure a comprehensive evaluation. These include a detailed pain history, social anamnesis, and a psychological assessment. For the detailed pain history, expanding beyond the PQRST approach, it's crucial to gather a thorough history of the patient's pain experience. This includes understanding the onset of symptoms, previous treatments, as well as the impact on daily activities. Pain does not exist in isolation, and the patient's social background plays an important role in its experience and management. Understanding a patient's occupation, living conditions, and social support systems as part of helps tailor treatment to their specific needs. Psychological factors such as depression, stress levels, and anxiety significantly influence the perception of pain. By exploring these emotional and psychological aspects, healthcare providers can offer a more holistic approach to pain management. Pain assessment is not a one-time event, but an ongoing process. After the initial assessment and treatment, the effectiveness of interventions should be evaluated regularly. Regular follow-up assessments ensure the treatment is working and allow for adjustments to achieve optimal pain relief. At second, the duration of a pain assessment depends on the patient's condition and the clinic's time constraints. In cases where patients are in severe pain, the assessment may need to be brief, focusing on the intensity, quality, and location of the pain to provide urgent relief. Finally, to ensure an effective assessment, accept the patient's self-reported pain as the primary and most accurate source of information, acknowledging that pain is subjective. Allow patients to describe their pain in their own words to avoid biased interpretation. Observing body language and emotional cues is critical, especially in emotionally charged situations. The essentials of the pain assessment process provide medical professionals with a solid basis. Pain assessments must be customized to fit the unique needs of variant age groups. Personalizing the assessment ensures that we capture the complexity of pain for each patient group. When assessing pain in different age groups, several challenges arise, especially the young and the elderly, as patients' populations have specific needs that ought to be considered. The term the young refers to children of varying ages and cognitive development. For our purposes, this group can be divided into 6 cohorts: neonates, infants, toddlers, preschoolers, school-aged children, and adolescents. Children at each stage of development pose distinct challenges to effective pain assessment. In neonates, behavioral observation is the primary tool, with family input helping to identify abnormal behaviors. Ethical guidelines must be followed, and it's important to note that absence of Discomfort doesn't mean the child is pain-free. For infants, pain may manifest as body rigidity, thrashing, crying, or hypersensitivity. They may also show signs like drawing knees to the chest or difficulty feeding and sleeping. Toddlers express pain through crying, resistance, guarding painful areas, or sleep issues. While some can express pain verbally, play and drawings help with nonverbal communications. Preschoolers may verbalize pain or show resistance and seek comfort. They might view pain as punishment, making trust building through child-friendly language and open-ended questions essential. School-aged children can describe pain but may show muscular rigidity or avoidance due to fear. Clear age-appropriate explanations and involving them in decisions help ease anxiety. Adolescents may deny pain in front of peers, exhibit tension, or have sleep issues. Genuine interest in their lives and avoiding confrontation promotes better communication. Aged patients face challenges such as visual, cognitive, or hearing impairments, as well as social norms which may prevent them from expressing pain. As a consequence, geriatric patients often receive inadequate pain relief due to communication barriers. The key rule is to ask about pain directly. For cognitively functional patients, adjust communication methods, larger text for the visually impaired or involving relatives, and avoid overwhelming them with too many topics. For non-communicative patients, pain assessment should rely on behavioral indicators like facial expressions, daily activity levels, emotional responses, and autonomic reactions rather than communication-based skills. Instrumental methods also may be used for pain diagnosis. Advanced instrumental methods such as quantitative sensory testing and electromyography are valuable for diagnosing chronic or neuropathic pain and assessing nerve function. These methods help in measuring pain thresholds and nerve responses, providing deeper insights into the understanding causes of pain. Age-appropriate and holistic pain assessment is also important. For pain assessment to be effective, it must consider both the physical and emotional dimensions of pain. Using age-appropriate tools and techniques is essential to achieving comprehensive pain management, addressing the specific challenges faced by different patient groups. Based on different patient needs, a variety of pain assessment tools exist. They can generally be divided into two categories, unidimensional and multidimensional. Unidimensional tools focus on one aspect of pain, typically its intensity, and are quick to administer, making them ideal for clinical settings. Multidimensional tools, on the other hand, offer a more comprehensive assessment by looking at different aspects of pain. While they take more time to use, they provide deeper insights into a patient's pain experience and are more fit for research purposes. The three unidimensional tools we commonly use to assess pain in adults. They are the visual analog scale in a 10 centimeter line with no pain at the end and vast pain imaginable at the other. Patients mark the line to indicate their pain level. The second is the numerical rating scale, which asks patients to rate their pain on scale of 0 to 10, which means at 0 level as no pain and at level 10 the worst pain imaginable. The third is the verbal descriptor scale, which involves asking patients to choose from a list of 6 pain descriptors ranging from no pain to worst pain possible to describe their pain intensity. For patients who have cognitive impairments or are too young to verbalize their pain clearly, specialized unidimensional tools have been developed. Among these are the Painart scale and Flex scale, and the Wong-Baker Faces Pain scale. The Painart scale is used to assess pain in patients with advanced dementia. It looks at nonverbal behaviors such as facial expressions, body language, and vocalizations, giving us a score from 0 to 10. For children under 3, we use Flex scale, which observes 5 behaviors: face, legs, activity, cry, and consolability. Each category is scored from 0 to 2, giving a total score between 0 and 10. For elder children, we often use the Wong-Baker Faces Pain Scale. This scale uses a series of cartoon faces ranging from a happy face for no head to sad, tearful face for head's worst. Children can simply point to the face that best represents how they feel. Relevant multidimensional tools which are used in practice are McGill Pain Questionnaire and the Pain Disability Index. The MPQ assesses 3 main aspects of pain: sensory, affective, and evaluative. It also includes a body diagram where patients mark areas of pain. The PDI, on the other hand, measures how pain affects different areas of patient's life, including family responsibilities, recreation, and self-care. Patients rate their level of impairment from 0 to 10 for each category. This tool helps us understand the broader impact pain has on their daily activities. Beyond traditional pain evaluation tools, instrumental methods provide detailed neurological insights, especially for chronic or neuropathic pain. Quantitative sensory testing helps diagnose peripheral nervous system disorders such as diabetic neuropathy by measuring pain and sensation thresholds for temperature and vibration. Electromyography and sensory nerve conduction studies measure how fast electrical impulses travel through nerves, identifying nerve damage in conditions like carpal tunnel syndrome and sciatic nerve injury. Evoked potential tests assessed electrical activity in the brain and spinal cord in response to stimuli. The 3 main types are brainstem auditory evoked response, which diagnoses auditory nerve issues; visual evoked potential, which diagnoses optic nerve or multiple sclerosis; and somatosensory evoked potential, which detects spinal cord damage, especially useful for peripheral nerve issues. Effective patient-centered pain assessment is not just a step, it's the foundation for quality care. The principle of non-malfeasance, which means avoiding unnecessary harm, is the extension of the Hippocratic Oath primum non nocere. Physicians must not inflict hurt according to Basham and Childress. Sometimes the best treatment is no treatment. In clinical practice, what effect negative over positive duties and ordinary over unusual are vital, and the benefit to harm balance must be continually balanced against anticipated dangers, including risk assessment, risk management, and non-malfeasance. Clinical training of healthcare professionals should aim to develop a feeling of ethical duty to put patients first at an early stage in their career. In oncology, non-malfeasance is a key principle that needs to be emphasized during the cancer care pathway. Overdiagnosis and overtreatment can harm individuals, violating the principle of non-malfeasance. The cancer treatment modalities, when used either as palliative or curative, can produce pain or toxicity, but justify non-malfeasance as their intent is to eliminate or mitigate the illness. During end-of-life scenarios, a nurse may not act deliberately to terminate life, but she has a moral obligation to provide interventions like terminal palliative sedation to relieve symptoms in dying patients. Justice is a complex ethical ideal emphasizing fairness, equality, and impartiality, and is the most essential criterion in medical ethics. It includes all other principles and is vital in patient care, health policy, and research ethics. It evaluates whether something is ethical, legal, fair, and balanced. Justice is foremost to bioethics and morality, and all decisions must be based on whether the actions treat everyone fairly in accordance to the rule of the land. Oncology carers must strive for social and equitable justice. Health equity, the opportunity for everyone to be as healthy as possible, unimpeded by their socio-economic situation or other socially determined constraints, is paramount in oncology. World Cancer Study reveals that gender means male versus female versus third gender, age means young versus old, race white versus black, domicile means rural versus urban, and socioeconomic means poor versus rich are some of the regularly documented inequalities in disease incidence, service, and treatment outcome. Healthcare practitioners should strive for fairness by treating all patients equally. Equity also means that the cancer survivors are rehabilitated and reintegrated into society post-treatment. In order to avoid individual economic concerns over the risk-benefit assessment of the possible treatment options, it is important that financial choices are undertaken at the highest decisional level and in any case as far as possible from the individual doctor-patient relationship. It is necessary to reduce the phenomenon of regional migration to gain access to innovative drugs, which involves inconvenience for patients and their families and may disadvantage the weaker, poorer parts of the population. The promotion of relationships with patient associations is fundamental for an active presence at the times of planned choices and an assessment of the perceived quality of the advantages offered by the service. Medical ethics requires professionalism, which means prioritizing patients' needs, upholding norms of competence and honesty, and advising society on health issues. Professionalism ensures safe, effective, and ethical health care and is guided by the tenets described in each discipline's code of conduct and focuses on the patient-client welfare and well-being in all healthcare decisions and activities. It is a complex domain that revolves around professional principles and role qualities such as respect for self and others, compassion, self-awareness, honesty, integrity, accountability, and a commitment to ongoing improvement and self-regulation. Healthcare staff must commit to quality improvement and safeguard patient privacy and confidentiality to gain the trust of patients and families. This dedication entails maintaining clinical competence and partnering with other experts to reduce medical error, improve patient safety, limit overuse of healthcare resources, optimize care, and help patients reintegrate into society. In oncology, professionalism reflects professional knowledge, skill, integrity, competence, honesty with patients, patient confidentiality, enhancing quality and access to care, just distribution of finite resources, sustaining trust through conflict management, and fulfilling professional responsibilities as essential constituents. On a non-clinical front, health practitioners should avoid unprofessional behavior such as inadvertent disrespect for coworkers, confidentiality breaches, and dishonesty about unpleasant experiences. Conscious attempts should be made to avoid personal confrontations with colleagues, patients, and visitors, and complaints must be handled discreetly and politely. Medical professionals should set limits with patients, protect vulnerable groups, and not abuse patients for sexual, personal, or financial gain. Medical professionals must communicate effectively and empathetically with the patients. The most frequently encountered ethical dilemmas by oncology nurses include the following: deciding not to perform cardiopulmonary resuscitation, telling the truth to the patient, studies being carried out without the patient's consent, and patient's refusal of treatment. In order to improve oncology nurses' critical thinking and ethical decision-making skills, it is important to determine ethical dilemmas encountered by oncology nurses, and nurses should be encouraged to be involved in ethical decision-making process through cooperation with the other healthcare personnel, both in the treatment choice and in the physician-patient relationships. All medical oncologists should always maintain an approach driven by rigorous scientific methodology. Empathy is the ability to understand another person's feelings and ideas and see things from the patient's perspective. This is innate but can be taught, practiced, and improved. Ethical decision making involves empathy and it helps healthcare workers to understand patients' perspectives and build trust. Listening, understanding, and paying attention to patients' emotions and what matters to them is a fundamental skill and needs to be reciprocated sincerely by each member of the healthcare team. An innate nature of empathy will help healthcare personnel make fair, patient-centered decisions in difficult and emotional situations. This will eventually help patients to bond trust with doctors and lead to a better healthcare experience by combining professional and emotional awareness among its stakeholders. Cancer patients who experience fear, anxiety, and despair need empathetic treatment. Patients relate physicians' manner, accessibility, and competence with empathy along with treatment skills. Perspective taking, nonverbal communication, real curiosity, active listening, and compassion are components of clinical empathy training. Empathy can be communicated vocally and nonverbally with a medical professional, like being closely seated with the patient and family carer and speaking with unhurried, softly spoken words. A gentle touch, especially when conveying bad news, a firmer touch or grip to convey reassurance to a patient facing a difficult treatment choice, to hold the hand of a patient who is dying alone, and all these things comforts the patients and needs to be indicated. Medical oncologists should take into account the preferences of the patient and his or her family members regarding the degree of involvement in the decision-making process, with particular attention to possible cultural differences. In the treatment relationships, medical oncologists must avoid demonstrating attitudes or behaviors that are incongruous with the suffering of the assisted person and that of family members. They should make every effort to establish a fruitful emotional alliance with the patient and family. The assisted person must be guaranteed continuity in the relationship with his or her own healthcare providers, both doctors and nurses, at all stages of the illness and be monitored by the National Health Service beyond the acute phase. Cultural competency is the ability to understand and incorporate elements of race, ethnicity, nationality, domicile, language, gender, socioeconomic status, physical and mental characteristics, sexual orientation and occupation into healthcare delivery and structure. Healthcare staff should avoid unintentionally categorizing patients based on ethnicity, religion, or cultural preferences and cross-cultural boundaries. Cultural competence, cultural sensitivity, and cultural humility strengthen medical ethics, which help healthcare workers serve better in their professions effectively and efficiently. Cultural differences, especially country-specific views, may affect cancer treatment decisions. Nations differ in economic, educational, resources, familial, and religious spiritual views on illness and health. Culture impacts aspects of health, disease, and death. Traditional societies consider cancer as a disease of the family, and everyone is engaged in diagnosis, treatment, support, conflicts, and finances and takes joint responsibility. On the contrary, Western civilizations value autonomy, empowerment, and personal responsibility as a disease. Religious views on health, sickness, and death vary in Eastern and Western traditions. While Westerners believe in overcoming nature and fighting disease to get well, Eastern civilizations practice passivity and fatalism to live in harmony with nature. Indian hospice patients seek religious and spiritual care with mental peace before death. This can cause an ethical dilemma for the cancer care team due to the interplay between utilitarian and deontological approaches. Considering the religious and spiritual dimensions in cancer care, doctors must reconcile conflicting belief systems to achieve optimum treatment goals, leading to mental satisfaction and the holistic well-being of the patient. Advanced care planning is a process whereby a patient, in consultation with healthcare providers, family members, and important others, makes decisions about his or her future health care. This planning may involve the preparation of a written advance directive completed by patients with they are capable. Advance directives are invoked in the event that the patient loses decision-making capacity. Advance directives may indicate what interventions patients would or would not want in various situations and whom they would want to name as healthcare surrogates to make treatment decisions on their behalf. Advanced care planning helps to ensure that the norm of consent is respected when sick people are no longer able to discuss their treatment options with physicians and thereby exercise control over the course of their care. This norm is grounded in the principle of self-determination and respect for autonomy. Advanced care planning also rests on the principle of respect for persons, and this respect must extend to those whose cultural values emphasize the interdependence of human beings and the well-being of the family or community as a whole. Most European countries have followed suit with provisions for advanced care planning. Medical oncologists should ensure the shared participation in end-of-life choices, in particular in that of treatment discontinuation. Treatment interruptions should not be perceived as abandonment, but as part of assistance. The role of the caregiver is not only that of respecting the dignity of the sick person, but also that of asking which relationship best serves the dignity of the sick person. The cost of treatments must be proportional to their efficacy and safety. Advanced care planning can help people to prepare for death, which, from the patient's perspective, tends to mean helping them to achieve a sense of control, relieving burdens on loved ones, and strengthening or reaching closer in relationship with loved ones. People who are dying want to attend to the needs of their loved ones, and patients fear that loved ones may bear the burdens of protracted terminal illness. The rights of palliative patients are listed in medical literature. The patient and family have the right to considerate and respectful care. The patient and family have right to obtain complete and current information concerning diagnosis, treatment, and prognosis in terms they can reasonably be expected to understand. The patient has the right to an appropriate assessment and management of pain and other symptoms. The patient has the right to receive from his or her physician information necessary to give informed consent before the start of any procedures and/or treatment. When the patient requests information concerning medical alternatives, the patient has the right to such information and to know the name of the person responsible for the procedures and/or treatment. The patient has a right to refuse treatment to the extent permitted by law and to be informed of the medical consequences of his or her actions. The patient has the right to every consideration of his or her privacy, confidentiality, and security concerning his or her personal hospice care program. The patient has the right to expect a reasonable continuity of care. The patient or family has the right to examine and receive an explanation of the bill regardless of the source of the payment. As part of the hospice team approach, the patient and family are involved in resolution of conflicts about care, service decisions, or ethical issues. The patient and family have the right to be involved in resolving ethical issues. The patient and family have the right to have complaints heard, reviewed, and, if possible, resolved. The patient and family have the right to have communication needs met. The patient and family have the right to be informed of assessment of physical, social, spiritual, psychological, and economic needs. The patient and family have the right to a plan of individual care, including assessment planning, implementation, and evaluation by the appropriate team member. The patient and family have the right to participate in decisions regarding delivery of care. The patient and family have the right to care guided according to their own religious principles. Actually, this list of rights is not comprehensive or unique or available for all categories of citizens, but this is a very good example of patients' rights listed in the literature source. Clinical trials are a fundamental part of cancer research as they establish the efficacy and safety of new cancer treatments for everyone. The lack of socio-demographic diversity among cancer clinical trial participant levels a vacuum in scientific knowledge which can distort credible evidence from being accessible and represents a major barriers to advancing cancer care for the entire patient population. It can also cause avoidable harm to the public, undermine patients' trust, and result in wasteful allocation of healthcare resources. It is therefore imperative that there is representation of all population groups who may use these new cancer treatments in clinical trial settings. Cancer clinical trials have contributed a major role in improving patient cancer care and outcomes, without which remarkable advances against cancer would not have been realized. In recent years, it has undoubtedly mounted unprecedented progress through transformative research and technological innovation, thus allowing more people than ever witnessed before to achieve longer and fuller lives following a cancer diagnosis. Spontaneous or independent research should be supported and encouraged, aimed at testing therapeutic strategies useful for clinical practice. It is hoped that there is organization with a coordinator ethic committee, regional or macro-regional, for the centralized evaluation of clinical trials. In the hospital, the presence of a clinical trials office to evaluate local feasibility and support the investigators is important. Participation in clinical research activity is of great value for the patient, for healthcare workers, and for participating centers. It should be properly recognized and appreciated as such by directors and senior management who conditions and supply the needed resources. These principles and responsibilities cover essential aspects of cancer patients' care and address all actors involved: patients, oncologists, the healthcare team, ethics committees, and institutions. Recent empirical work in oncology suggests that patients with cancer who participated in clinical trials received, apart from the specific study treatment, a net benefit, namely improved survival. Ethical issues in research must not be addressed by researchers as an afterthought. Researchers ought therefore to consider ethical issues from the first stages of planning. A critical component is assuring the protection of human subjects in research is the prior review and approval of any study by an ethics review committee. The differences between the role of physician and that of researcher become readily apparent in the definitions of clinical research and medical practice. The Belmont report distinguishes the difference between these activities as follows. For the most part, the term practice refers to interventions that are designed solely to enhance the well-being of an individual patient and that have a reasonable expectation of success. By contrast, the term research designates an activity designed to test an hypothesis, permit conclusions to be drawn, and thereby to develop or contribute to generalizable knowledge. Clinical research enrolling patients as research subjects is essential for the efficient development of safer and more effective treatment, but because of the differences between research and clinical practice, clinical research is given special regulatory oversight and research subjects are afforded special protections. When physicians who treat patients also engage in clinical research, they take on a dual role because the activities in which they engage have elements of both the clinician and the researcher. These roles have important differences that can conflict or become blurred. The differences in the conduct and goals of clinical research and medical practice can affect informed consent, alter the rights and duties of patient subject and clinical investigators and give rise to conflicts of interest. There are several key issues for clinicians considering involvement in research. First of all, understanding the scientific justification for conducting clinical research and what counts as an acceptable balance of risks, of harms, and potential benefits in clinical research. A second, avoiding exploitation of patient subjects and promoting justice in recruitment, enrollment, and the post-trial care of patients. Also, ensuring that patients' participation in research is voluntary and adequately informed, and also properly managing the dual roles of physician and researcher. There is a great deal of ethical, legal, regulatory, and policy guidance addressing both clinical research and medical practice. However, little of this guidance addresses the particular challenges of the physician's dual role. Cancerophobia is a morbid dread of being afflicted by cancer. There are two types of patients who consult physicians in connection with the fear of having cancer and in whom malignancy cannot be detected. Those who fall into the cancerophobia classification can accept reassurance and regain normal status. Those who present the delusion of cancer are unable to accept reassurance and become increasingly anxious. In this second group, need for psychiatric treatment may be overlooked even when it has become urgent. It is important to differentiate between the two groups. It is reasonable and even helpful to have some levels of fear about cancer. That motivates us to get screening tests such as colonoscopies and to promptly report suspicious lumps or spots to our doctors. It also is normal to feel anxious when we go to mammogram, for instance, and to feel relief when the scan is negative. With cancerophobia, however, a person gets caught up in the cycle of anxiety and the reassurance she or he gains from being told that everything is fine. The biggest factor in fighting cancer today is health education. People need to be informed about the risk factors for cancer and the guidelines for early detection. The most effective way to protect against cancer is to change negative lifestyle habits and behaviors. Following are some guidelines for preventing cancer. For most people who do not use tobacco, increased physical activity and dietary choices are the most important modifiable risk factors.